Right now, there is probably a box of ibuprofen somewhere in your home, maybe in your medicine cabinet, maybe in your purse, maybe on your nightstand because your back has been bad this week and you just needed something to get through the day. You've been taking it for years, and here's what nobody told you. After 60, with the kidney function most of us already have, that pill is doing something your body quietly cannot recover from. I'm Dr. Grace Wells. I work with older adults on kidney and metabolic health, and today I need to walk you through something that I genuinely wish more doctors were saying out loud in their appointments. Because this isn't rare. This isn't a 1 in a million warning on the side of a label. This is one of the most common causes of sudden kidney decline that I see in people over 60, and almost nobody connects it to the ibuprofen they took 3 days ago. Let's start with why your kidneys are different now than they were at 45. By the time we're in our 60s, most of us have already lost somewhere between 30 and 40% of our kidney filtering capacity, just from normal aging. That's not disease, that's just time. And here's the thing about kidneys, they don't announce that. Your creatinine can look fine on a lab report. Your doctor might not flag anything. You feel completely normal, but your kidneys are working at a reduced margin. And that margin matters enormously when a medication enters the picture. Now, I want to explain the mechanism here because once you understand what's actually happening inside your body, you'll never think about ibuprofen the same way. Your kidneys are constantly managing blood pressure and blood flow to their own tissue. They do this using chemical messengers called prostaglandins. Think of prostaglandins as the valves. They keep the small blood vessels feeding your kidney tissue open, dilated, so that blood keeps moving through and your kidneys keep filtering. When you take ibuprofen, naproxen, diclofenac, any of the NSAIDs, what those drugs do is block prostaglandin production. That's actually why they work for pain. Prostaglandins are also part of the inflammation pathway. But inside your kidneys, blocking those prostaglandins means the valves close, the vessels constrict, blood flow drops, and in a kidney that already has reduced capacity, that drop in blood flow can trigger what we call acute kidney injury, sometimes from a single dose. I want you to stay with that for a moment, not after a week of heavy use. After one pill, in someone with existing kidney disease or even just age-related decline, one dose can be enough to push the kidney into crisis. Now let me tell you who is most at risk because there are several groups where the danger is significantly amplified. Age over 60 is already a major risk factor on its own, for the reasons I just described. But if you also have chronic kidney disease, even early stage, even stage 2, the margin for damage is much thinner. If you have diabetes, your kidneys are already under consistent vascular stress from years of blood sugar fluctuation. Adding an NSAID on top of that is like applying pressure to something that's already been weakened. If you have high blood pressure, and especially if you're taking a diuretic for it, a water pill, the risk jumps again. Diuretics reduce fluid volume in the body. NSAIDs cause fluid retention and narrow the blood vessels. Together, they can create a perfect storm for the kidney. If you're on an ACE inhibitor or an ARB for blood pressure or heart protection, medications like lisinopril, losartan, ramipril, adding an NSAID creates what's called a triple whammy combination. The research on this is not subtle. It's one of the most well-documented drug interactions in nephrology. Let me give you the specific list of medications you need to recognize. Ibuprofen, Advil, Motrin. This is the one I hear about most. People take it freely because it's been over the counter for so long that it feels harmless. Naproxen, Aleve, sold as long-lasting relief, and it is. It also stays in your system longer, which means the kidney impact is extended. Diclofenac, Voltaren tablets. Now, I will come back to the gel form of this in a moment because it's a different story. But the oral tablet is a full systemic NSAID, celecoxib, Celebrex. This one is a COX-2 inhibitor, which was initially thought to be safer for kidneys. The data has not supported that. It carries real kidney risk, especially in higher doses and in our population. High-dose aspirin, and I want to be clear about this because low-dose aspirin, the 81 milligram cardio dose, is a different category. But aspirin taken for pain at 325 milligrams or higher, regularly, does carry NSAID-related kidney risk. I know what some of you are thinking right now. But Dr. Wells, I'm in pain. My arthritis is real. My back is real. What am I supposed to do instead? That is exactly the right question, and I'm going to give you real answers. Acetaminophen, Tylenol, is the first-line recommendation for pain management in people with kidney disease. It does not affect prostaglandins. It does not constrict kidney blood vessels. The important caveat: the standard dose limit is 3 to 4 grams per day for healthy adults, but in people with kidney disease or liver concerns, the safer ceiling is 2 grams per day. And I want you to actually count your doses because acetaminophen is in more combination products than most people realize. Cold medicine, sleep aids, prescription pain medications, always check the label. Now, here's the one you might not know about: topical diclofenac gel, Voltaren gel. When you apply an NSAID to your skin directly over a joint, the absorption into the bloodstream is dramatically lower than when you swallow a tablet. We're talking roughly 6 to 7% systemic absorption versus nearly 100% with oral forms. That means meaningful local pain relief with a fraction of the kidney exposure. For joint pain, knee, hand, shoulder, this is genuinely worth discussing with your doctor. Physical therapy is the one I want to say more firmly than I usually do. It is consistently underutilized and undervalued by people who are managing chronic pain. A good physical therapist working specifically with older adults can reduce pain in ways that outlast any pill, because they're actually addressing the mechanical problem. Heat and cold therapy, pacing, movement modification, these aren't lesser alternatives. For a lot of my patients, once they've properly addressed the underlying mechanics, they find they need far less medication. Before I give you the questions for your doctor, I want to tell you something that I think is important to hear. If you've been taking ibuprofen regularly and you have kidney disease, or you think you might, I don't want you to panic. The kidney is a remarkably resilient organ, especially when the threat is removed early. But what I don't want is for you to keep doing something that's quietly eroding that resilience while you feel perfectly fine. The whole problem with kidney decline is that it doesn't hurt. It doesn't send signals the way your back does. You don't feel your GFR dropping. You feel your back, so you treat your back. And in the meantime, something you can't feel is getting worse. That's why this conversation matters. At your next appointment, I want you to ask these exact 3 questions. First, given my current kidney function and all the medications I'm on, is it safe for me to take ibuprofen or naproxen? Don't assume your doctor has done this calculation. They're managing many things in a short appointment. Be direct. Ask them to confirm it for your specific situation. Second, can we check my GFR and creatinine? And if I've been taking NSAIDs regularly, do we need to check sooner than my next routine labs? This is especially important if you've had a period of regular NSAID use and haven't had labs checked recently. Third, what pain management alternatives would you recommend for me specifically, given my kidney health? That last one is important because it puts the responsibility on the right side of the conversation. You're not asking permission to stop something. You're asking your doctor to help you do something smarter. Write those down if you need to, or take a screenshot of this part. And if someone you love, a parent, a sibling, a friend, is in this age group and living with back pain or arthritis, send them this video. Not because I want more views, because they're probably doing exactly what you were doing before you started watching this. Reaching for something that feels safe because it's been in the medicine cabinet for 20 years. That's not their fault. It's just information that hasn't reached them yet. Your kidneys are doing something extraordinary for you right now, quietly, without asking for anything. They filter about 150 liters of blood every single day. They regulate your blood pressure. They keep your chemistry balanced. They're doing it right now while you watch this. The least we can do is make sure we're not making their job harder with something we don't actually need. Next week, I'm covering metformin, because if you or someone you love is diabetic and has kidney disease, there is a very specific line where metformin goes from being one of the safest medications in the world to being dangerous. And a lot of patients don't know where that line is. That one might be even more important than this one. I'll see you then.